like your pregnancy test, HIV card test, or the hepatitis B card test. The only problem with D-dimer test is the D-dimer is negative, we are in a soundtrack and we can exclude the disease. If it is positive, it drives us crazy and we have to do several tests like an compression ultrasound, a repeat ultrasound, and probably some more work upon the patient. D-dimer, the critical concentration of D-dimer to be called positive is more than 500 nanograms per ml. If we have a patient who is suspected to have DVT, we have to follow this algorithm. Determination of the pretest probability of DVT is done using the chart that is given earlier, that is the Wells pretest probability scoring. Now we end up with two types of scenarios. DVT unlikely if the probability score is less than 1 or 1. 1 or 0, the probability of DVT is very unlikely. In such a patient, no imaging work is done, only D-dimer test is done. What is D-dimer? We will see in the next slide. If the D-dimer test is positive, then an ultrasound is ordered. If the D-dimer test is negative, DVT is ruled out and patient can be worked up for other causes of leg pain. If the ultrasound is positive after the D-dimer, then that patient is treated with anticoagulation for DVT. If the ultrasound is negative, even though the D-dimer is positive, if the probability score is 1 or less, even though if the D-dimer is positive, the ultrasound is negative, DVT is ruled out. Now we have got the other arm where DVT is highly likely if the probability score is more than 1, that is 2 or more is the score, then in such a situation DVT is a likely possibility. Then we order for D-dimer test. D-dimer can be positive, D-dimer can be negative. If the D-dimer is positive, then we do a compression ultrasound. The compression ultrasound is positive, then the patient is treated with anticoagulation therapy and the diagnosis of DVT is confirmed. Supposing the ultrasound is negative, it cannot totally rule out DVT. Patient is called back once again after a week and repeat ultrasound is done. If the repeat ultrasound is negative, then of course DVT is ruled out. Repeat ultrasound is positive, he is treated with anticoagulation. So the other scenario is patient has got DVT score likely, that is more than 1, and the ultrasound is D-dimer test is negative, then we ordered an ultrasound. Ultrasound is negative, of course no DVT in spite of the pretest probability score being higher. D-dimer and ultrasound, if both of them are negative, we can safely rule out DVT. Of course, if the ultrasound is positive, even though the D-dimer is negative, then the patient is treated with anticoagulation therapy for the diagnosis of DVT. This is the algorithm proposed by Welsh and internationally accepted and very easy to follow. There are only two tests involved. First thing is the pretest probability, clinical probability score, then of course the D-dimer test, and then of course the compression ultrasound. With these three things in hand, we will be able to make a diagnosis and start treatment for any patient of DVT. After assigning the points for each of those clinical findings in the previous chart, we will obtain the total score of the patient. If the total score is 1 or less, DVT is a very unlikely possibility. In such a patient, no imaging is required. What all we need is only to reassure the patient and call him back. Of course, D-dimer will be tested. If the D-dimer is negative, patient is sent home and no imaging. Supposing if the score is 2 or more, DVT is a likely diagnosis, very likely diagnosis. D-dimer test is done and compression ultrasound is ordered. How to use this D-dimer test and compression ultrasound we will see in the algorithm that follows in the next slide. Remember, never rule out DVT on clinical grounds alone without assigning the Wells score and without doing D-dimer or US if the total score is more than 1, that is at least 2 or more. Some companies are working on developing a rapid diagnostic test kit for DVT, just like the hepatitis test kit or the HIV card test kit. And this is how, with a small finger prick and a drop of blood, we will be able to pick up whether the D dimer is positive or negative. In a few days, probably these test kits will also be available commercially and in our country too. Why should we treat DVT? Half of the DVT patients have some degree of pulmonary thromboembolism, though it is asymptomatic. The beauty of pulmonary embolism is patients do not complain of pulmonary embolism. We may not suspect it until it is too late. But DVT is symptomatic. DVT will have a sore leg, a swollen leg, a red and bruised leg. There will be rash on the leg. With this symptomatic DVT, with these symptoms of DVT, if we do not pick up the clue and start preventing pulmonary embolism, we will be doing a great disservice, and many people may die due to the embolization into the lungs. That is why it is very essential to diagnose DVT and to treat it promptly with anticoagulant. After working up the patient on clinical grounds, if the Wells score is less than 1 or 1, it says the probability of DVT is very low and it is an unlikely diagnosis. In such a patient, we need not give low molecular weight heparin. We have to work him up with D dimer. Do a D dimer. If D dimer is negative, D dimer is a very strong sensitive test. So if it is negative, it rules out the disease. The pretest probability is low, D dimer is negative, what further thing you require? Diagnosis of DVT is excluded, look for other causes of the pain in the limb. But if the Wells score is 2 or more, the probability of DVT is higher, and such a patient, irrespective of the further testing, should immediately receive the benefit of 1 injection of low molecular weight heparin. Then of course we order the D dimer, and the D dimer could be positive or negative. Then use the compression ultrasound, use the algorithm, and then confirm or refute the diagnosis of DVT. Positive ultrasound means, irrespective of D dimer being negative or positive, if the compression ultrasound is positive, it is the clinching test for diagnosing DVT, and standard anticoagulation should be given for 3 months minimum. If the ultrasound first time is negative, but if the D dimer is positive, then we still have a doubt, and such patients must be re-examined by compression ultrasound at the end of 7 days. If the 7-day second ultrasound is positive, then diagnosis of DVT is confirmed and patient is treated with anticoagulants. If the repeat ultrasound is also negative, then the patient is excluded from the diagnosis of DVT and other causes are worked out. Then the question is, how long we give the anticoagulation? The duration of treatment for DVT depends upon the following factors. We can roughly divide the patients into 5 groups. Patients who have proximal DVT, which is transient in nature, and he does not have any other risk factor associated. In such an individual, 1 week of heparinization followed by 3 months of oral anticoagulation with warfarin. The second group of patients are patients who are patients of malignancy, either actively being treated or palliative treatment with DVT. Their risk for recurrent DVT is much higher, and such patients must get low molecular weight heparin for a period of at least 6 months. The third category of patients are those who have DVT confirmed now, but who also have a thrombophilic profile, like pregnancy, like estrogens, like patients who have family history of DVT, and patients who are positive for factor V and phospholipid antibodies and all such thrombophilic profile patients must receive low molecular weight heparin for at least a period of 1 year, because they are potentially very high risk group of people for recurrent DVT and PE. The fourth category is recurrent DVT occurring again and again. In such patients, 3 to 6 months of subcutaneous heparin first, followed by oral heparin later, for a total duration of 3 to 6 months has to be given. Then if we have DVT without any risk factor whatsoever, then minimum of 6 months we give the treatment and then continue if necessary the treatment for 1 year using oral anticoagulants. Okay, now the question is, which is the anticoagulant I choose? Heparin, low molecular weight heparin, oral anticoagulation? What should be our choice? Intravenous heparin is out of treatment for years, so we can safely forget about using intravenous heparin. Subcutaneous unfractionated conventional heparin is much cheaper compared to the newer low molecular weight heparins. The conventional heparin is given in a dose of 333 units per kilogram initially, first dose, and the subsequent doses will be 250 units per kilogram given BID subcutaneous. This is not inferior to low molecular weight heparins like dalteparin or enoxaparin. Supposing we decide to use low molecular weight heparins, enoxaparin in a dose of 1 mg per kilogram BID subcutaneous, if the eGFR is less than 30, then 1 mg per kilogram per day will be the dose and not BID. Dalteparin 40 mg given once a day, very convenient. If the eGFR is less, the dose of 30 mg is given once a day instead of 40 mg. Fondaparinux is a newer agent, it's the latest agent and has got no documented thrombocytopenia, and it is given in a dose of 7.5 mg subcutaneous irrespective of the body weight. These are some of the different parenteral anticoagulants available. Oral anticoagulation with warfarin or comodin after 1 week of unfractionated heparin or low molecular weight heparin can be given in some patients, and we have to try and keep the INR, international normalized ratio, of more than 2 to keep the anticoagulant status in the blood. Risk of bleeding with the above regimens is minimal. The risk benefit ratio is very high, and it is essential that every patient of DVT is put on anticoagulant.